you're live.
Hi everyone, good afternoon. My name is Neerja. I am a genetic counselor, senior genetic counselor, and a vice president of genetic counseling at Map My Genome. It's my immense pleasure and honor to have a wonderful team of experts with me today to discuss colorectal cancers and its prevention, as well as current screening and some of the challenges that families might be facing. This is definitely something that a lot of people and families have come and asked us about, a lot of questions that are commonly being raised. So it's my pleasure to have a very important group of people with me here who can answer some of these questions. I'm going to quickly invite our panelists here and discuss about them, and then we can get started with the rest of the questions. Um, Dr. Vijay Palwa with us here is present. He is the head of department and chief radiation oncologist of the department radiation oncology. Dr. Palwa is an expert in management of all types of cancers, including head and neck, breast oncology, esophageal malignancies, and brain tumors. He is also an expert in various types of therapies of cancers, including tomotherapy, renal accelerators, IMRT, etc. He's been specially trained at Tata Memorial Hospital, Mumbai, in basic chemotherapy administration with a wide range of adult pediatric solid tumors. Welcome, Dr. Palwa. We have Dr. Ritu Sethi, who's a senior consultant obstetrics and gynecology at Cloud9 Hospitals. She's a leading practitioner in the field of obstetrics and gynec in the last 20 years. Her professional profile spans from various range of hospitals here. She's an alumnus of the prestigious Hagen Medical College, Delhi, where she's completed her MBBS and her MD in 2003. She's also been instrumental in organizing several workshops, conducting antenatal sessions and seminars. She also has participated in several national conferences and, as faculty and paper on biochemical parameters like preeclampsia has been published. She's a member of the Gurgaon Obstetrics and Gynecology Society, as well as a member of the Federation of Obstetrics and Gynecology and Medical Council of India. Welcome, Dr. Ritu.
Thank you so much for inviting me. Thank you so much.
It's a pleasure. Dr. Satish, he's a director of clinical trials, professor and academic in charge of Department of Medical College at HCG, and senior consultant medical oncologist at HCG and SOS. Dr. Satish is a senior consultant and professor of medical oncology, has special areas of interest such as lung, breast cancer, precision medicine, and targeted therapy in oncology. He's an award winner of the Young Oncologist Developing Nation Award at ESMO ECO 2009. He has also presented both at national and international conferences and has participated in many cancer detection camps in rural on a regular basis. Welcome, Dr. Satish. And then we also have Dr. Akar Kapoor, who's the medical advisor, chief radiologist at City Scan and Clinic Private Limited. He is completed his MBBS at UCMC and Delhi University and MD at Radio Diagnosis from Belgaum. He is academically oriented and has completed numerous CMEs. His special interest lies in radiology, CT, and MRI. And he's repeatedly appreciated for his dedication in sincerity in radiology. Welcome, Dr. Akar Kapoor. Thank you, everyone, for being here and for participating in this wonderful discussion. I will start with some questions around, what are the contributing lifestyle factors? And I'll ask Dr. Akar to please answer these questions. So, Dr. Akar, can you tell us a little bit about what are the largest contributing lifestyle factors and environmental factors in colorectal cancer? And how can we modify the risk by altering our lifestyle?
Firstly, Neerja, thank you so much for having us, and special thanks for that. So, colorectal carcinomas are one of the third leading cause of cancers and affect almost about 12.3 lakh people every year. And the deaths involve almost 6 lakhs people, affect 6 lakh people every year. And the incidence is expected to increase up to 77%. And the deaths are also expected to increase approximately 80% up to 2030. So it is an alarming number. And there are various risk factors. Firstly, any underlying conditions like the inflammatory bowel disease, which includes the Crohn's disease as well as ulcerative colitis, or there may be familial or genetic conditions like the familial adenomatosis polyposis FAP, or the hereditary non-polyposis colorectal cancer, which is the Lynch syndrome. There may be underlying predisposing conditions. Based on the lifestyle factors or the personal factors which lead to increased incidence of the colorectal cancers. These include chronic smoking, excessive alcohol intake, and also consuming a lot of these processed as well as the red meats, which include pork, lamb, etc. And also, when there is a low fiber diet and high consumption of high saturated fats, a diet which is less of vegetables and fruits may lead to increased incidence. Obesity is one of the important causes, and having a sedentary life also predisposes. The most common age group of having colorectal cancer is above the age of 50, but although nowadays we are seeing a very early incidence of this disease, even between the age groups of 20 to 49 years of age. So we must keep a very healthy lifestyle, keep ourselves hydrated, and try to have a plant-based diet, and try to avoid these red meat, smoked foods, processed foods, which are predisposing to these conditions. One must work out and also avoid having a sedentary lifestyle. So these are few of the predisposing factors. Also, in ethnicity and the race, a few of the American Indians and the Jews most commonly are predisposed to this colorectal cancers. Yeah.
Thank you so much, Dr. Akash, for going over that. Now, when we also look at, screenings, like we know that, for example, for breast screening, we have so many kinds of screenings, like doing a mammography or doing a sonography. Now, what types of screenings are available for colorectal cancers? And also, when do we start doing these screenings?
So screening is ideally advisable in people who have a predisposing underlying condition or a lifestyle disorder, and it is a very important aspect in such cases, because the main aim is to pick up this cancer early. The earlier we diagnose, the more easy is the treatment, of more better is the prognosis, and there is increased 5-year survival rate. So the various screening methods that are available to us are the lab investigations. For example, the fecal occult blood test, the fecal immunochemical test. There is a flexible sigmoidoscopy in which the rectum or the lower part of the colon can be screened through a scope, as well as we have the conventional colonoscopy. We also nowadays, a very upcoming procedure is CT colonography, which is a virtual colonoscopy. So many of these patients which have these risk factors or these predisposing conditions, underlying conditions, can go for these. CT colonography is gaining wide acceptance because many of the lesions cause obstruction and don't let the scope pass beyond that site of the lesion. So CT colonography can help to even see the part of the colon beyond this site. Also, many of the lesions are synchronous lesions. That means approximately 5 to 11% of these lesions involve different segments. So, colonography help to evaluate various other parts of the colon. Also, many extracolonic aspects can also be evaluated, like, for example, metastasis to the liver, to the lymph nodes, to the lungs may be evaluated, or the extracolonic spread can also be seen with the help of this CT colonography. So it is gaining wide acceptance. So ideally, they say that colonoscopy should be done once in 10 years. Although there may be a lot of discomfort and there is a lot of stigma associated with colonoscopy. However, it is definitely, this discomfort is temporary and will help save many lives. But however, screening is advised in people with predisposing conditions, both genetic, familial, as well as lifestyle disorders.
Understood. So, in terms of the, you addressed this just now, is that, a lot of people are hesitant for it. So, what are the preparation or process involved in these procedures for colonoscopy? And also, are there any risks and precautions that people have to take?
So colonoscopy requires, so basically a good preparation for a colonoscopy will lead to an accurate and a successful procedure. The preparation is the utmost important step. A patient who has to undergo a colonoscopy in the near future for 3 to 4 days should have a low fiber diet. A day before the procedure should be on liquids and should avoid solids, and should also take laxatives in the evening or a night before the procedure. Should be near a washroom because would have diarrhea and would need to go to the washroom frequently, and would need to be comfortable that ways, and this would help in clearing the bowel. And before the procedure, around 3 to 4 or maybe 5 hours, there should be absolutely no intake of even liquids. And patient should be hydrated 1 or 2 days before that, so that he's well in a condition to undergo the procedure. And after the procedure, because during the procedure, CO2 has to be passed in order to distend the bowel before the scope can be passed. A patient may feel discomfort or lower abdominal pain after the procedure, and there may be some infection because it is a scope has to be passed into the bowel. So there may be antibiotic cover after the procedure. There may be per-rectal bleeding that the patient might have after the procedure, and if it does not stop in a day or two, must get in touch with the clinician. One of the very rare complications of this procedure are intestinal perforation, but it is done by trained GI specialists, so it is very rare. However, we need to inform the patients well before that. So one of the advantages of a colonoscopy are that the clinician can take a biopsy there and then of the lesion if there is any suspected polyp or a mass or a lesion that has to be evaluated. So it can be used as a screening modality, a diagnostic modality, and even to get a conclusive diagnosis, this biopsy, which can be done along with the procedure. So there it gains points over a virtual colonoscopy because this histopathological biopsy, which can be taken there and then during the procedure, cannot be performed in a colonoscopy. So these are the various preparations, precautions that the patient needs, and the side effects and few of the risk factors for a colonoscopy.
Thank you so much. Thank you for explaining that. So, are there any blood tumor markers that can detect colorectal cancers?
So CEA, which is a carcinoembryonic antigen, is the most frequently used blood marker in case of a colorectal cancer. However, it is not very specific. It may be normal in a case of colorectal cancer or may be elevated in other types of cancers as well. So it has to be clubbed along with a clinical examination as well as with the other reports, which also need, the other imaging modalities also need to be evaluated along with this monitoring of the CEA. However, it is the most frequently used tumor marker for a colorectal cancer.
Perfect. Thank you so much. And finally, if you could shed some light on common symptoms of colorectal cancer for everybody here.
So colorectal cancers have a wide range of symptoms that the patient may present with. It may be loss of appetite, irregular bowel habits, bleeding per rectum. The patient may even present with a lump abdomen. The other day, I got a patient with a lump abdomen, and when we were just doing the ultrasound, I felt a mass in the lower abdomen, and a CT was prescribed, and eventually it was a advanced stage colorectal cancer. So it may be a lump abdomen, per rectal bleeding. Patient may have a weight loss, loss of appetite, and yeah, pretty much these are the common symptoms that the patient may present with in
Sure.
this condition.
Sure. All right. Thank you so much, Dr. Akash. Thank you for your insightful responses. Dr. Vijay, can you shed some light on the survival rates of colorectal cancer, especially when they're diagnosed early?
Yeah. Hi. As Dr. Akar has elaborately explained about the risk factors and the tests. Um, when it comes to the survival rates in colorectal carcinomas, when we can diagnose these patients early, like in stage 1, the survival rates which we see in normally oncological malignancies is in 5 years, 5 year survival rate. So in stage 1 or early stages, it is approximately 85 to 90% of the people can survive beyond 5 years if they are diagnosed early. But unfortunately, only 30 to 35% of the people are only diagnosed in early stages. So when the stage advances to second or third stage, then the survival rate, 5 year survival rate, will be approximately 65 to 70. And as the stage progresses to the metastatic stage or stage 4, then 5 year survival rate are dismal, like in that 15 to 20% only. So unfortunately, in India, not many patients are diagnosed in early stages, and an emphasis has to be done on diagnosing them in early stages, so that the cure can be, we can definitely cure this patient.
Definitely. So it sounds like one of the biggest challenges that we face is the early diagnosis and the awareness for that factor right now. Now, let's talk a little bit about the treatment itself. So, what's happening in terms of advancement in treatment? Do we have new treatment procedures, robotic surgeries, or laparoscopies that have changed colorectal cancer treatment?
Uh, Actually, since over these last 2 decades, there have been many advancements, not only in surgery but in radiation therapy in medical oncology field itself. So there have been a lot of advancements, like from open surgery we have transformed into laparoscopic and now robotic surgeries also. And in laparoscopic surgeries also, there are some advanced technologies like single incision laparoscopic surgery, or there are some surgeries called as natural orifice transluminal endoscopic surgery. So these are new advancements in laparoscopic surgery. When it comes to radiation, there are many techniques like intensity modulated radiation therapy or image guided IMRT, and tomotherapy, and nowadays proton therapy. So there are many advanced technologies by which we can precisely target the tumor, and at the same time we can spare the normal surrounding structures, and we can accurately or maximize the tumor control, at the same time minimizing the side effects. And in medical oncology, I think there are many panelists, medical oncology panelists also, so they'll be able to guide us more regarding chemotherapies. But there are definitely some monoclonal antibodies like trastuzumab, pertuzumab, and some kinase inhibitors like tucatinib or lapatinib. So they are definitely proving to be a good help for treating these cancers.
So they are more and more personalized, are getting more personalized, which definitely helps in reducing the toxicity of the treatments as well as improve the efficiency in terms of the outcomes. Now, a lot of patients ask these questions is what is my life going to be post surgery for colorectal cancers? Because they hear about colectomy bags, they hear about a lot of different kinds of things from, other patients or families, or read it online. So can you shed some light about what are the significant lifestyle or dietary changes somebody may undergo post surgeries? And also, following with that, what resources do we have for families who are recovering for maybe a colectomy or other treatments from colorectal cancer?
As I mentioned in the newer techniques, a person who is undergoing colectomy may have to be subjected. I am not a surgeon; I am a radiation oncologist, but still I take that opportunity to whatever I can share with you. The person who is undergoing colectomy can be subjected to either temporary or permanent colostomy, depending on the surgery. As far as we are like doing robotic surgeries and laparoscopic surgeries, the benefit of these newer technologies is shorter duration of stay, because with the complex mechanisms and the magnification you can see in the robotic or laparoscopic, the duration of there is actually intraoperatively the blood loss is very minimal. Post-operative recovery is very good, and the shorter duration of hospital stays. So, if a patient is subjected for colostomy post surgery, uh, definitely it is a impact in on his both of physical and mental also. So, what a patient can expect from colostomy tube is it has to, like, it is a bag which is to be which the patient has to carry along with him. There can be some complications like skin excoriation. There can be complications like seepage or leakage, or um, uh, patient might be feeling ashamed when it comes to, like, going out in the public. So there are many and mainly patient has to modify his dietary habits, like taking low residue, low fiber diet, less spicy foods, less fried foods, avoid meats. So there are many lifestyle changes the patient has to make.
Correct. Thank you. And then can you talk a little bit about now when you see families who are at risk of an inherited cancer syndrome, how do you promote testing or increase screening for these families in your practice, or what kinds of information would you tell these families that are important for them to identify who are the ones who are at risk of an inherited cancer syndrome?
I think, as Dr. Akar has precisely pointed out, that approximately 5 to 10% of these colorectal malignancies are hereditary. So, a patient who is having at high risk of having colorectal carcinoma, like familial polyposis coli syndrome, or patient is having inflammatory bowel disease like Crohn's disease or ulcerative colitis. So these patients, relatives of these patients, needs to be screened at regular or frequent intervals than normal public. Generally, we ask the patients to general public to get screened after 45, and with either stool for occult blood testing. It can be colonoscopy or flexible sigmoidoscopy, or different techniques like fecal immunological tests. So the high risk patients need to be screened at regular interval and at frequent regular interval than the normal people.
Absolutely. And the only thing I would, also add over there is, as genetic counselors, we often see families who come in, ask about, oh, my parent or a sibling had a colorectal cancer, or there is uterine cancer at a young age of onset. So we definitely do screen them genetically. Also, we offer them some genetic
Correct.
testing to identify who are the ones at an increased risk, because there is, as you have rightly mentioned, there's a lot of screenings to be done and can be found early if there is an increased risk for cancer, which leads to a better treatment and an early treatment and a good prognosis. Thank you, Dr. Vijay, for your insightful answers. Dr. Ritu, I have some questions for you more specific to females, who have been diagnosed. So one of the concerns that I have noticed quite often in our practice is that, we do find that women are often identified much later with their symptoms. So how often do you see that women with symptoms of colorectal cancer getting misdiagnosed or having a delayed diagnosis? And what do you think causes this? Dr. Ritu, you're on mute, please.
Yeah, can you hear me now? So first of all, we notice that a lot of women, are usually diagnosed in the later stages, though colorectal cancer is less, the incidence is lower than the men. But still, usually women tend to be detected at a later stage. The most common reason for that is that the symptoms of colorectal cancer are usually so vague, like, bloating, abdominal pain, pelvic pain, loss of weight, that women usually tend to confuse it with other symptoms. Like, for example, the most common of these is endometriosis. Any woman who's coming to me in a clinic with such kind of vague symptoms, probably colorectal cancer would be the last thing on my mind. I would probably get a workup done for endometriosis. Maybe, most clinicians, especially gynecologists, tend to dismiss the syndrome as premenstrual syndromes also. So these kind of patients usually get missed a lot. And women tend to complain of, intermenstrual bleeding, passage of, when they start complaining of passage of blood in stool and other complaints, then we think of ulcerative colitis or maybe Crohn's disease, inflammatory bowel disease. But any woman who's coming with a history of pain, abdomen, pelvic pain, these are very common in a gynae setup. And we usually don't actually, as a clinician also, I also would say that I would be guilty of not kind of, raising a red flag when they come to me with these kind of symptoms. So definitely these symptoms are really an eye-opener for all gynecologists also, that yes, because colorectal cancer is on the rise, especially in younger women in India. It's not just after the age of 50 years. It's definitely much on the rise. So we should be going ahead and thinking of a possibility of colorectal cancer also, in case a patient comes to me with abdominal distension, bloating, loss of appetite, and not really feeling like eating anything, persistent vomiting episodes. So as yes, inflammatory bowel disease is also definitely much more, but unless the patient doesn't come out with a history of that, we don't really tend to think of colorectal cancer, because like I said, in India it's not that common. And usually in postmenopausal women, we would think of colorectal cancer, but not in the younger population. So because of that, these women tend to be diagnosed late, and when they are diagnosed, usually it is at a later stage, when maybe a peritoneal spread has occurred, it has spread to the liver, maybe even to the ovaries, and this is the reason that colorectal cancer tends to be detected at a much later stage. Now, one thing I would like to point out is that premenstrual syndrome and things like PCOD, in which patients have intermenstrual bleeding, women usually tend to confuse their symptoms a lot, leading to clinicians also thinking that maybe these are symptoms of probably abnormal bleeding, is probably a symptom of, they're not able to exactly tell us that, doctor, I'm having intermenstrual bleeding. They would probably just come to us like that. When we ask them, when we kind of, probe them even more, then they would tell us that, no, doctor, they're feeling very shy in telling us that I'm having bleeding through the anus, I'm passing blood in the sperm. And this is the reason that women are getting diagnosed at a much later stage, and the symptoms could be picked up much earlier. The signs of colorectal cancer, if they are present in a woman, they could be picked up much earlier, in case women would come out with their symptoms much earlier to us. But like I said, because they are mimicking so many gynae conditions, that is the main reason that we tend to miss out a lot of women, and it comes at a later stage.
Correct. Thank you so much, Dr. Ritu. I think very important concern, because it really raises awareness towards that we need to put colorectal cancer on our differential diagnosis, when you're looking at some of these symptoms. Do you find that women are more fearful or shy to go through colorectal cancer screening? Do they have any inhibitions about this?
See, in case a diagnosis is made, I would just say that they are not really very shy about it. But yes, it is definitely comes at a shock, because probably that was the last thing which they would have thought of. Their symptoms mostly would be dismissed as a premenstrual syndrome, endometriotic symptom, even if something is picked up on a simple ultrasound. The most common symptom which would come to a gynecologist's mind would be, it's probably intestinal endometriosis, or peritoneal implants are present of the endometriotic tissue. So in case a sigmoidoscopy, a colonoscopy reveals that it's colon cancer, only then women would be more accepting of it. Most of them are in the denial mode, of course, but yes, it would probably be the last thing on a clinician's mind too, as a gynecologist. So I think we gynecologists are lacking in that kind of awareness also. Right. It's an eye-opener for all of us.
Sure. So when you find these, combination of symptoms that you're looking at, which can, get misdiagnosed for other gynecological concerns, what do you think are the differentiating tests or screenings that really helps you differentiate this from the remaining conditions that you see?
Yeah, in case, of course, a CT scan is going to something which is going to guide me, a sigmoidoscopy, a colonoscopy. In women, usually those women who are having those who are having ovarian cancer, I would also think of a familiar, reason for this. And again, look out for colorectal cancer. A woman who's had endometrial cancer at a young age, again, it would probably raise a red flag that yes, she might. Any woman who has undergone, radiation, especially for cancer cervix at a younger age. I have had one or two of my patients who've had colorectal cancer because they have undergone irradiation of the pelvis for CS cervix. Another reason why women are very fearful is because of the loss of fertility. It's such a, I would say, personal thing for them that, doctor, I will probably have to undergo radiation. I would have to undergo surgery for my problem. So what happens to my fertility? See, usually colorectal cancer is something which is being detected after the age of 50 years. But in case it's coming at a younger age and with the kind of drugs which we are giving, especially the platinum containing drugs, they are really chemotoxic. They are really, toxic to the ovaries, and the fertility goes for a toss. So these women will have to be again counseled about their fertility too. So as a gynecologist, I would say any patient who is undergoing treatment for cancers, they do come to us because the surgeon sent them that you can go and meet your gynecologist. She will tell you all the options, how you can preserve your eggs, what you can do so that your fertility, your eggs can be used later on. You can probably undergo IVF earlier. You can get your embryos frozen and you can get them implanted at a later stage. So these are the most common reasons why women who have undergone, treatment for colon cancer are going to undergo treatment for colon cancer would be coming to me as a gynecologist. See, upfront, I would not be seeing these patients, probably sending them to the other departments. But for these issues, women would be coming to me. And the main reason why women are very fearful is, again, loss of fertility, like I said.
Right, right. Which are genuine, valid reasons, and I think you've addressed the fact that now with the ART, the artificial reproductive technologies, we are able to at least help the women, store and freeze their eggs and then probably use them later when an IVF technique. Now, when you see a lot of females with ovarian cancers at the young age or uterine cancers with young age, we know that some of these may also be in that bracket of individuals who have Lynch syndrome or have a higher risk of developing colorectal cancer because of an inherited cancer syndrome. So, how open are they, in your experience, for genetic testing? Because that does increase the risk of other cancers, and also how open are these families to talk about this with their family members who are at risk, like their siblings or parents?
No, actually, in case we probe them further, they are quite upfront and quite forthcoming about the fact that yes, we don't want to put our relatives also to a risk, about these crimes. So, doctor, please go ahead, get all the investigations and everything done, because we don't want that our family members should also, in case they are at a risk, they should be kind of treated in time, or detected. The cancer should be detected in time. So, women, of course, are quite upfront and forthcoming. Though the cost of the test is a little, I would say, it's costing around 20,000-25,000. The Lynch testing, I think that is the cost. That may
It's coming down now. Yeah, it's coming down. It's, I think, coming down to about 13,000-14,000 at this point. But yes, I would still say it's for an average Indian, it could still be an expensive test.
Yeah, something like the BRCA gene,
Yes.
we are getting it done quite often because we are seeing more and more women of breast cancer coming to us. So we are asking them to get tested. And the same thing goes for Lynch and for familial adenomatous polyposis conditions, that the test would be, maybe the cost is a little prohibitory. So where to stop is another big question mark, where to stop testing the patients, which all relatives have to be screened, You can't be screening each and every person in the family. So that just adds up to the cost. But in case the costs come down, I'm sure women would be more than willing to come ahead, to go ahead with the tests.
Correct. Makes sense. Thank you so much. So if you were, what would your advice be to women? Like, we do have cervical cancer screening, which I think now women are more and more open to. They get through their pap smears on a regular basis. Same in terms of their breast screening. So what would your advice be for women to take care of their risk for colorectal cancer?
Yeah, again, I would just tell women that because obesity is very much on the rise, PCOD was a new epidemic for us after COVID. Of obesity. So again, because of the lifestyle, weight gain, sedentary lifestyle, weight gain, eating more of processed food, saturated fats, like Dr. Akar pointed out, definitely the incidence of colorectal cancer has been increasing. So we are advising patients that, we can't be aping the West, seeing the dietary lifestyle. And breast cancer, again, is the #1 cancer in India these days because of the Western habits we have adopted. Same goes for colorectal cancer. It's again on the rise. A cancer which was not present very much in India is again on the rise because of the Western lifestyle we are adapting. So my advice to all my patients would be maintain a good lifestyle, adequate, proper weight, proper BMI, eat high fiber diet, make sure you're active, you're exercising more frequently. And in case you're having a family history, please go ahead and get yourself screened.
Thank you so much, Dr. Ritu. I think they're very insightful, advice to take away for all the women who are watching this, in terms of screening for colorectal cancer. Dr. Satish, I have some important questions in terms of research, and I think really in terms of what would your recommendation be in terms of clinical trials. But before we get there, I have one more question for you. Is that often people who have inflammatory bowel disease, whether it's ulcerative colitis or IBS in general, the symptoms are very overlapping. And what would you advise for people who already have an inflammatory bowel disease? Because we are now seeing that autoimmune conditions are also on the rise. Many people have been getting diagnosed with autoimmune conditions, IBS as well as ulcerative colitis being one of those. So, what's your recommendation for people when they have concerns or symptoms that looks like an IBS, but they have still not, had a final diagnosis about
Yeah. This IBS, definitely it is a challenging like beginning at the diagnosis, and if they're in the beginning phase of the disease, we treat them early by the proper gastroenterologist. It can be treated early, it can cure it, and it can control very well, but needs to have proper follow-up, periodic follow-up of these cases. If you don't have a proper follow-up, then lead to have complications like on second malignancy. The rise in the colorectal cancer definitely we are seeing. Then we have to have the periodic follow-up at least once in 3 to 5 years with to be in the regular gastroenterologist. The already old case of inflammatory bowel disease, they have a periodic follow-up of either they are having difficulty to get a colonoscopy. At least you can have virtual colonoscopy because they are these candidates are the high likely to develop a colorectal cancer. This is one of these my suggestion.
Right.
If we coming to the general clinical trial, definitely the challenges what we are facing in India, it is not as good as definitely love to see that new articles, new protocol is coming, what is coming we are reading from Western country, but we are not able to apply in our day-to-day practice in even clinical research also. What we are facing in our patients in India, colorectal cancer, we see very early compared to Western country, almost 2 decades. The median age in our Indian patient is 47, but is when you compare to Western country, 71 years means. But if you divide into colon and rectal, you see that more of left-sided colon and rectal cancers will see more common compared to Western country. And they're also advanced stage and the younger age. We'll see that less than 40 years, we can say almost approximately 35 to 40%. That is a real very challenging for us. We don't know what is the cause for this. We'll say that colorectal cancer major etiology is the aging, and I think Akar has pointed out various the contributor. I'm not going to repetition of that because we don't have a genetic contribution. Is there syndromes, but still 70-80% we don't answer for this. This is one of the unmet big challenges for our Indian patients. Definitely the incidence is rising, in this case, and also we are seeing it is day to day advanced stage and prognosis not good in younger patient. What we have to address? Yes.
Go ahead, sorry. Go ahead. Let you complete.
What we have to do research in our Indian patient is why these cases we are seeing in younger age compared to Western country. We don't know. Similar to even breast cancer also, we don't have answer. And we don't have a exact what are the reason behind that. Will be the hypothesis there, epidemiology study. Okay, we'll see more likely in the younger age. Is there any our dietary pattern, lifestyle, how we do Western country in detail in that analysis, reason behind that? Can we modify the risk factors? We are not doing in our Indian practice. That we should come forward. Actually, that is not a one person or not like clinical research people. They'll come. They're having some segment of what is the hypothesis. There is some idea is there. They have to prove it, but it has to collaborate, work from the cancer history and all cancer research like cancer hospital and local body. They have to get involved like IME. They should help actually. It is one of the common how you see diabetes, hypertension, cardiac, how is the cases rising. this cancer also definitely it is a major challenge for us. And next thing is what we have to do research in our how even though we see in younger age, how they are biologically different than Western country. We'll try to use the same protocol, same treatment regimen, but still we don't see good result what we see in Western country. Do they have a biology? They're definitely they're aggressive. What we see, why they're different, like biologically in-depth deep dive of the analysis of molecular biology is important in our case. That's what that drives us to have a new answer. Even though new drug, it has to go research, but at least by doing extensive genomic analysis, in-depth analysis of the biomarker in these cases, we'll try to find out at least some of the older drug I can put in treat in the advanced cancers. And can we go for any the reason if we find out, can we identify early and we can prevent these kind of the habit changes in the patient. That's what we have to see. The other like lot of research is going on in advance in the treatment, like Akar and Vijay was telling robotic surgery and a newer like modality of intensive like IMRT, IGRT, tomotherapy, even ethos, newer adaptive radiotherapy. A lot of things have come, but can we the many Dr. Ritu was telling, gynec patients very difficult because when the low rectal cancer is very common in India, was more the curative treatment is a surgery and additional along with the radiation plus chemotherapy is must based on the what is the size stage based treatment we are supposed to do it. Here, challenge is like when you go for a curative surgery, the splinter like colostomy is there. People are just staying, they're going away from the doctor. They try to seek some other some alternative therapy.
Alternatives,
These things
definitely.
are these are challenges for us actually. When you're going for a curative treatment, the right time they're not taking. Then will come back after the lot of multiple alternative therapy. Then they'll come back with the metastatic disease. Doctor, you do something great thing, miracle. That it is really challenging for us, because let us the research should go in this. Can you have alternative the sphincter sparing surgery? There are other alternative modality. Can you have a near equivalent result? These are research you should go. That's what these are challenges are there in front of us.
Correct. Well, you have
Yes, you
raised
have
three very important areas of research, and thanks for bringing that up. One being that I think we do have to do a profiling of all the mutations, both germline and somatic, which will really help us understand, are there any drivers, that is causing a different pathology? Maybe that's why the medications and the treatment don't work. Like you said, they work in the West. And then if they don't, then how do we identify the biomarkers that can help us identify an medication or treatments that can be more specialized and personalized for our population? Second is, why do we see a younger age of onset? Is there an underlying, and I think we genetic counselors have been pushing for this, is that we don't see as many families with, now breast cancer, things have changing a little bit. We see more and more breast cancer coming in for testing because of the presence of olaparib. We don't see the same with Lynch syndrome or FAP. We don't see a lot of families or family members or patients getting tested for colorectal cancer, even when there is an early onset. And that is something we've been really pushing for. We've been bringing a lot of awareness. But I think it's necessary, because I definitely think that we lack in a lot of mutational profiling is still lacking in our country. For breast cancer, we have seen that other than high risk genes like BRCA1 and 2, there are many common biomarkers and SNPs, single nucleotide polymorphisms, that have been found in the general population, pushing the risk. Plus our lifestyles, like Dr. Ritu pointed out, following Western lifestyle added to that risk factor. We don't know the same for colorectal cancer, and I think that is what we really need right now. Then finally, you also pointed out about the surgeries. How do we better our surgery so that it can be, it won't be as life changing as some for family members, and not as scary for family members. And then the fourth thing that it brings me all of this is the access to, barriers to access to all of these treatments. I mean, we definitely have a huge barrier in geographical access. A lot of patients have to travel long distances to urban cities to get any of these. So how do we break those barriers in bringing in more and more government setups and centers that can offer the same treatments to everybody across India, right? So are there any active clinical trials going on in CRC and colorectal cancers in India right now, Dr. Satish?
Yeah, this is a good question. Really, that Indian, like a lot of trials are going on in breast and lung cancer. Even we do see, we come across colorectal cancer. What India is lacking is clinical trial in most of the common cancers. There's a challenge because it gives an important opportunity for doctors and even for a patient to participate. They can get at least a standard and even the good newer treatment options also. Sometimes it is even better than the standard treatment. That's
Right.
what is lacking in India. But we have a few trials in India, especially we are seeing biosimilar bevacizumab. Now cetuximab is coming in the this colorectal cancer. We have a like that bioequivalent study of we try to have a newer drug like oral trifluridine is there that we have done FDA studies on those things. And now, like a drug conjugate, we'll see that trastuzumab, deruxtecan. These are newer drugs that is especially those are on HER2 positive. We can try to tackle. Immunotherapy, I think in a coming few years, maybe 1 or 2 years, the biosimilars are starting. That will come. That is one of the important area we'll try to access for the drug and trials also. Definitely, most of trials are running in the breast and lung cancer and some other hematological cancer based on the what molecule they are to test. But definitely, it is a challenging to get involved in the most of the patient in the clinical trial. Trials in India are very few. Definitely, we should make that importance understand the biology, try to explore newer options, biomarker, try to do our own study, how we are different from the Western country, existing treatment that we should analyze. Even real data analysis also even more important is near equivalent to clinical trial. That most of clinicians should come forward because here like we are not finding sponsors coming forward and doing the studies. They are most likely restricted. Some Indian companies they are coming very limited, small by similar studies that we are coming. But definitely, I'm a part of many global studies, but they're all running in a various cancers. Colon cancer, they definitely will come in the near future. We'll have more immunotherapy trials. Yes.
So, if a patient wants to look up or wants to access some of this information, is there a particular website like how we have clinicaltrials.org? Like, do we have any such websites or any place where a patient can get access to or a family member can get access?
Yeah, there's a global studies is there clinical trials.go is there. That is like not only NCA based and even non-NCA based throughout the globally. Any trials are there. There has to register actually that you can able to access actually. For Indian trials, that is CTRI, that is Clinical Trial Registry of India is there. There we can able to access actually those are which are the centers they're running trials in India. We can able to access actually which are the areas, which cancer, which molecule, whether it's a biosimilar study or like as intervention study, non-intervention, all the things you can able to get information through this website. People they don't search actually that they want the easy spoon feeding that information. Like the doctor should aware of these trials are going on. They should answer the patient. They're really smart. They're like now everybody they're using a smartphone or those things. They should make an effort to do the way these trials are running in this hospital. If you search, at least they can have one of the opportunity. They can help their colleagues, friends, and family members.
Yeah. Absolutely. And then what do you think that we must do as a medical fraternity, in terms of collaboration to create a registry? One of the things is that we don't have an active registry to count the incidences well or to see what is the mutational profile. So what do you think that we as a medical fraternity can do to collaborate that, to create the registries or to understand what the genetic burden of the predisposition of these cancers are and what is the mutational profile are for these?
See that the cancer history, most of the hospital, those who are treating cancer patients, there's a cancer history there, incidence and the death rate, other thing, they have to report it. Like that, they're supposed to have most of the cancer hospital, they might have majority of the standard basic information of the lab test and even genomic test. Sometimes some hospitals, small hospital, they try to tie up with the genomic lab in a bigger city. At least you should collaborate with the genomic lab and along with the hospital cancer history. Those are the key persons are there. They should give that what are genomic changes are there in each patient, in each cancer. If you put it together, collaborate, but it needs effort. It's the support from doctors, definitely, because if you don't write proper diagnosis, you cannot able to register properly. That's one of the common mistakes, even the cancer history also we are finding. If you do have a proper data information, and even along with the genomic changes is there, along with the help of genomic lab support, pathologists and molecular pathologists, they should help us to make a collaboration coming together. Some NGOs like should come forward actually, because no one is coming, bringing them together and try to make it effort to drive that registry. That will help actually. We can get a lot of publications and also helpful for our common patient, all patient of India. At least our the cancer typing like that genomics, biology of disease like this, we are different than Western country. At least what we can do, is there any preventive measures are there, or any drug access we can able to get because of this genomic changes? Like a research should come actually.
Right. Definitely. Thank you so much, Dr.
Yeah.
Satish, for insightful responses there. And I think a lot of thought-provoking, responses that can help us also push towards the right direction. We have a last couple of minutes, and I would like to open it to all the panelists to see if they would like to share some last-minute thoughts or questions or advices really to our audiences today. Dr. Akar, I'll start with you. Any last-minute, thoughts, or you think take home messages for us?
You've spoken about a lot of screening methods, treatment, and research work. When a patient goes to a doctor, the two things is the one most important thing is a good clinical examination. A digital rectal examination for people, or even a per abdominal examination is very important. We might pick up very important information by doing a good clinical examination. So many times patient may miss it, or even these are painless or non-tender lumps, or even a DRE, which is a digital rectal examination, may find lesions which the patients may be asymptomatic with. So this is a very important part which I wanted to add.
Sure.
And
Thank you, Dr. Akar.
yeah,
Yeah, go ahead. Anything else?
apart from that, I feel that CT colonoscopy, which I had emphasized, is gaining a lot of importance these days. So, in a few of the American Society of Gastroenterology, this has also been at places been accepted as a modality of screening, whereas in the European Society of Gastroenterology, it has still not been incorporated in the screening methods. But it is a very upcoming modality. If a proper preparation can be done and the distension of the bowel can be seen, there can be a lot of scope in screening, because patients do have apprehensions about the conventional colonoscopy.
Correct. Correct. Absolutely. Rightly said, doctors. Like there's a lot of inhibition, to go through a colonoscopy.
Correct.
So if there is a more non-invasive way, I think people will be more open and more happier to go through that, and more open to consider that as a procedure. Dr. Vijay, any last thoughts for us?
Yeah, actually, though colorectal carcinomas are not the most common cancers in India right now, but over these years, the incidence has definitely increased, and it is on the verge of increasing more and more. So early detection is the key to improve the survival and cure the disease. And even if there is I just need to tell to the general people, if even if there is a diagnosis of malignancy, there is no need to be panicked, and there are so many advanced technologies, treatments like robotic surgeries in radiation oncology also, and in medical oncology also. So the side effects which were used to be earlier before 10 or 15 years back, they are not. That is not the case right now. So even if there is a diagnosis of malignancy, nobody should be panicked, and definitely medical help should be taken at the earliest, and the cancer can be cured.
Perfect. Yes, that is very true. Is that the treatments have improved. There is a better outcome now as we did in the past in the last few years, and that's definitely something that for all of us to remember is not to be as fearful of a cancer, cancer diagnosis overall. Thank you, Dr. Vijay. Dr. Ritu, any thoughts for us to from your clinic and from your experience?
Just increasing the awareness about the symptoms and increasing the awareness about the need for prevention too. I would also emphasize on prevention and a holistic lifestyle for approach to the entire matter. That would just be my take on this.
Definitely, definitely, and I think you've shared some very insightful thoughts about how a lot of the diagnosis, whether it's PCOD or endometriosis, does overlap with colorectal cancer in the initial phases. So I definitely would remember that with when we see somebody who has concerns and symptoms of endometriosis, is also to remind them that you want to speak to your doctors about any family history of colorectal cancer, any personal concerns with any bleeding when you're passing stools, or any other symptoms that they may not have thought through really right now. Definitely. Thank you so much, Dr. Ritu, for your insightful thoughts today. Dr. Satish, any last minute thoughts for us or any thought provoking, advices that can help us as a medical community to push forward now?
Okay, I think my colleagues there already they put insight regarding the screening is key. The symptoms should not neglect. The people is scared actually. Any symptoms, there are some people that has cancer. Don't worry about that. Any symptoms is like not getting relieved by more than like 6 to 8 weeks. That something is wrong in your body. It need not be cancer. It may be something else. Please
Mm-hmm.
consult a relevant specialty. They try to answer. See, no doctor like this. Sometimes you need investigation. People they want a shortcut. They prescribe some medication. If your doctor is told some test, no doctor, I'll come later. Please try to discuss with them. Like the awareness should come. If the persistent any symptom more than like 6 to 8 weeks, should get investigated. Something is wrong. It may not cancer. It may not have a cancer, and once you have the cancer, you have a thorough discussion with your group of oncologists. It may be surgical, medical, and radiation oncologist. They'll give a proper insight. And don't go for a shortcuts. Actually, that the people they try to hear about the surgical part and maybe some treatment part side effect. You have a like maybe it may not be one session is not enough. You have a proper discussion that people try to hear a word from some patient have a some tragedy. It may not be like a true in your case. You should have a proper knowledge, thorough, and information about all the cancer treatment. Then only take a right decision and right treatment at early stage. You have a proper treatment. Then definitely you have a highest chance of possible cure. Don't try to have an option of getting recurrence half-hearted treatment. That's one suggestion I want to tell all the people are getting involved and watching this. The next, like proper follow-up is required. Like that is most important. Like for a couple of years, maybe like 3 to 5 years is most important. Once you cross 5 years, definitely will tell you your label as you got cured of the disease. But if you have some general health problem, maybe you should be conscious about health education about general health maintenance. The last one thing is you should doctor also should aware, and even the patient cancer patient should know that any options like a clinical trials are there. Definitely discuss with your respective oncologist. Is there is a right treatment? Is there like is inferior treatment? Is something that people are there doing experimenting on my body? You have proper information. It may be the best treatment option in your case. And people they try to because of financial burden, many people they're not opting for the best cost treatment. Monoclonal antibody, immunotherapy. These are like there's a most of things day to day we see that they try to go for a very simple like a common basic cytotoxic drug. They're not able to go for an advanced cancer like an advanced stage. The target treatment like it is not feasible because of it. They're all expensive because of availability of biosimilar. That cost of treatment is coming down. That's what we are currently observing for 5 10 years. Definitely in the future we'll have a lot of new drugs will come, but you should apply if any clinical trial options are there. Please discuss with your team of doctor and person who is involved in the clinical trial. Get a proper thorough information, then you take a decision whether to should participate or not. you take advantage of this. That's what I wanted to tell. Thank you.
Definitely. Thank you, Dr. Satish, and bringing in important points of, not leaving the cancer treatment halfway through, and, making sure that we can have a successful remission and a successful cure only when we are able to trust our doctors, go through the entire procedure as recommended by them. And although it can be difficult sometimes, to make sure that we can take them in confidence and, go through the entire procedure. It has been a pleasure. Thank you, everyone, all the panel, especially for taking out your time today to being a part of this wonderful session and sharing some very insightful responses to important queries, questions, concerns that families have brought to us. Thank you, to everybody here at the audience, to IHW for an opportunity to share this platform with all the experts today in this panel talk. Thanks, everyone. Have a good evening.
Thank you so
I hope
much.
to see you all
Thank
soon.
you.
Thanks.
Thank you. Thank you, everyone.